there's this attitude among working people that if I feel okay, I'm going to work.
Right. There's also an opportunity cost. If they don't go to work, they're not going to be covered for that day. They're not going to receive money. They need money. There's no backup that they have, so they have to go to work. It's also worth thinking about how easy it is for them to access specialty care. This woman was talking about how she was going to get her daughter to a neurologist. In some of the communities that we did our research in, it was one thing to get primary care which might be close to them, for example, the community health centers. And that might be accessible, but the specialty care, which may exist 30, 40, 50, 80 miles away, are not accessible for a variety of reasons. They may not have transportation, but even more importantly, if they leave their home community, they expose themselves to being identified and deported when they leave the safety of that small, enclosed community.
So when we saw a glimpse of the daughter, that child is probably an American citizen. The woman said she came here in 2002. So yet, for all that legal status in a mixed status family, it's probably going to be, she's probably going to be less likely to get the help she needs than other American kids, right, Dr. Castro?
Yes, it's as was mentioned, we do have, to a certain extent, access at local levels, at the local community centers. It's slightly different in the rural areas and the urban areas. But when you do identify, for example, I'm working with the Mexican consulate here in New York, and one of their problems is that they have little health sessions in the consulate, and their biggest concern was, yes, we have these screening, we identify problems, but then once we identify these problems that go beyond just primary care issues, what do we do with them? Either they because they don't have insurance, they cannot be plugged into specialty care, or then even if they do get plugged into specialty care, they're lost in the system because they cannot navigate themselves, either because of linguistic or just cultural issues. So it is a major problem that we might have some access at the primary care level, but they are totally lost in the more specialty care, higher level care.
That primary versus specialist tension, are people less likely to trust, because you've both talked about trust, Jenny and James, less likely to trust that they're protected, that they're not going to be in trouble if they expose themselves when they move out of that community setting, even though they care a lot about getting the kid the help they need, even though they care a lot about getting this secondary treatment because they know something's wrong, are they less likely to go get it, or less likely to get it in a longitudinal, effective, over time kind of way?
Well, first of all, for many documented Americans, getting specialty care is very problematic. And for undocumented folks, and I can talk specifically about farm workers, the cost of seeing a specialist and finding a specialist who will see you, especially if you're only here for a short while and you're going to leave, getting an appointment is very complicated. So in our system, which just makes such great sense, we set up, if we feel somebody needs specialty follow-up, we set up a specialist appointment. We find somebody who will see this patient, and our outreach workers go with them to interpret and also to advocate for them and to have them feeling like they're safe. That's probably the first thing we do as a healthcare system in community health and in migrant health, is build trust. And one of the significant features and most important features of our system is having outreach workers who are usually part of the culture that we serve, speak the language.
How does that get paid for?
We beg and borrow. We don't steal, but we try to get people to give us that care when we can. If we there is a migrant health program in the Finger Lakes area. They have an understanding with all of the they have specialists in their network, $50 a visit. That's it. That's what they pay, and really, it's I think a tribute to people's generosity that there are medical professionals out there who will honor that.
Is there a sense, Jenny, that like law firms that expect their staff to do a bit of pro bono work along with their billed hours, that doctors in a care-short system, and any system that leaves 50 million people uncovered is a care-short system by definition. Is there a sense on all kinds of providers' parts that they have to give a little along with the stuff they get paid for?
I think so. And I think that people who come from a public health perspective, who understand that it makes more sense cost-wise, it makes more sense public health-wise to provide care to more people, people get that and they're willing to be a part of it. But I also think that the financial constraints are serious as well, and I think the big issue is specialty care, and it's hard to find. I mean, in certain parts of the country, especially in New York, hospitals are obligated to provide financial assistance to folks who are uninsured and are low income. It gets much more complicated and much harder with private physicians, many of whom work at hospitals. They don't have those same kind of legal obligations, so that's one unfortunate thing. But there's also a lot of really good models around the country, in San Francisco, in DC, in Toledo, in Cleveland and other places, where you have networks of providers that have come together, including specialty providers, and have decided, okay, we're all going to share the burden together of caring for the uninsured, not just undocumented immigrants, but all the uninsured. And we are going to come together and provide discounted care to people who need specialty care, and try to strengthen the system so that people get their primary care, they get their preventive care, they get their specialty care when needed. They work with pharmacies to get more affordable prescriptions, and those are some really good models, and we need to find a better way to fund those.